Hey, welcome to Health or Hoax. My name is Anthony Davis.
I'm Blake Loxterkamp.
And we have Dr. MacDonald with us, who is was a fellow at the HPC, has just opened private practice, is teaching at the HPC. Welcome to our show.
Yeah, no, I'm excited to be here. I am an adjunct faculty member at Northwestern, which is how I got to meet these two. I own my own practice in Edina. It's Mobility, Agility, Chiropractic Performance, which shortens to MAC Performance. Yeah. Nobody notices that.
It took me a while.
It does. It takes me a while. I predominantly work with athletes, but that's not exclusive. I do have not athletes in practice. I work with the Minnesota Roller Derby as their team chiro, and a couple semi-pro men's team, and Drum Corps National Marching Band as their team chiro.
You got a lot going on.
Oh yeah, it's the best way to be.
Enough. How long have you been? When did you graduate again? I
graduated in November of 2015.
Cool.
So 5 years this fall.
That's awesome.
Mm-hmm.
So we have had the pleasure of having you at Northwestern, where we go to school, and we're really glad to talk to you today about chiropractic and about how to treat injuries and things like that. But we'll get into that in a second. I think it's really interesting to hear from chiropractors because there's a lot of controversy or misconceptions, let's say, about what chiropractors do, what they don't do. And you ask 100 chiropractors, they're going to give a different answer. So I'd like to know, what do you think a chiropractor is?
I see a chiropractor as a primary care musculoskeletal specialist. So no matter what walks in the door, I help navigate my patients through the health system, get the referrals they need, but my specialty is musculoskeletal.
Cool. Joints, muscles, bones, whatever.
Yep.
Head to toe, all that business. Excellent. Cool. So one of the things that I think we've noticed in our coursework creating a schism between what we're learning and then what else exists in the whole outside academia land is we seem to be getting a lot of messages in school about, somebody's hurt, and there's a lot of sort of pampering them, a lot of bracing and orthotics and stay home and ice it and compress it and rest it and don't touch it. You're going to break.
You're fragile. Don't stop doing your activity. Like I've seen chiropractors write doctor's notes so that like student athletes didn't have to go lift weights, so their adjustments would go better. And that just seems like nonsense. As a personal trainer, that seems like nonsense to me.
So I will say that the research within this realm is aggressively changing right now.
Yeah.
Even within how long we hold people to what we're doing, it's drastically changing. When I was in school, they were still talking about Rice and Price, and granted, I graduated in 2015. That's not that long ago.
Right.
That's changed. It was police for like half a second where they had taken out the R of rest and switched it to optimum loading.
Okay.
And now they've changed it to like peace and love.
That's my favorite one.
Peace and love.
Yeah.
And they've completely gotten rid of anything to do with ice.
Okay.
I will say ice has a benefit in one specific area, and that is acute injuries. Like, you rolled your ankle right here, right now.
Right.
Within those first 2 to 3 hours when there is superficial bleeding going on, and we're trying to control some of the pain with ice, it's a great option.
Right. And you're working with some populations, I think, that not everybody would know that a chiropractor would be involved in. So sidelines and things like that. So you're right there when it happens.
I'm a dual license. So I'm a DC, and then I have both national and international sports certifications, but I'm also a nationally registered EMT.
Right.
So I've kind of blended those into being a solid sideline provider. And sports chiropractors don't have to be sideline providers. Mm-hmm. They don't have to enjoy that. I know specifically a prior guest of yours, Dr. Alex, he doesn't always enjoy sideline life. And I think he's said that he prefers to see them in the office, in the weight room.
Sure.
I might be putting words in his mouth, but that's just conversations we had last year versus like, I want to be right there. I want to be the first responder on the scene so I can start initiating care and getting them better faster.
Yeah.
So in acute instances, in those situations, I'll use ice because I want to manage shock. I want to manage pain. I want to manage bleeding. Mm-hmm. Those are really the three things I use ice for. Once it's like the next day I'm seeing them, we're not icing anymore. Mm-hmm. Sure. We need some level of inflammation to actually help proliferation of the cells and actually get the tendons to start healing. Mm-hmm. They have poor vasculature. Right. Tendons, I mean, obviously you guys have been through histology. I'm sure you love that class.
I actually really thought histology was interesting.
Histology's
learning about how everything works on a cellular level is, I don't know, I think that's pretty cool.
But this is where you get to apply that. You have to have some level of inflammation to actually get those ligaments and joints to heal. Mm-hmm. Yeah. But they also require loading. So tendinitis, tendinopathies, sprains all require loading to actually get effective healing. So it's not so much removing them from activity, it's modifying it so they don't further injure themselves.
Right.
That makes sense.
Yeah, and regarding the ice too, I mean, just generally speaking, yeah, they need the blood flow, essentially, because that's how it's carrying all that important stuff that all those cells need to heal themselves.
And that's sometimes really hard. Like there are times I'm on a sideline and a kid walks over wanting ice. I ask why and they're like, "Oh, I always ice after games." I'm not gonna argue with them. I'm not gonna fight the coach. I'm not gonna be like, "Hey, we're not gonna do this. This is pointless."
Yeah.
Because it's one of those, unless I'm like the team provider, it's a pointless fight that might get me not invited back to that venue.
Yeah.
But if I am in charge of that team, then I implement the reduction in ice utilization to help healing.
I wonder if you, if you're not thinking about this particular subject, then feel free to ignore this. But I think it was Dr. Stark who was talking about this, where he was proposing a theory. I hope I'm not misunderstanding it. That sometimes with ice, because depending on how you use it, your skin gets red, right?
Yes.
The only reason it's going to get red is because there's increased vasculature, which is the opposite, right? Yeah, that's the face I was making, because obviously ice is a vasoconstrictor, so reduced blood flow. But I wonder if that's just if you leave it on for long enough. If it's like 20 minutes, then it goes numb, then it goes white. But if you maybe do it temporarily, and something about the Huntington response, increase in the vasculature.
So I'm just going to speak from this thought process of we're more looking at, I don't think it's actually increasing vasculature.
Okay.
So we have to think of hypothermia and we have to look at freezer burn. And you might actually be freezing and burning the skin. Mm-hmm. So you're getting a erythematous response because you're actually causing damage, not necessarily bringing blood flow or increasing blood flow. You're just damaging the skin.
Interesting. Yeah, I guess it seems like from looking at ice, the only thing that seems useful to me is, I mean, obviously in acute situations where the inflammation is just like crazy out of control, you're swelling like crazy, or just in general as a painkiller.
Yeah, it is.
But movement is a painkiller, right?
Yeah, so I will ice patients. So if I have an acute ankle injury and they're not willing to weight bear because of pain, like we've cleared them of fracture, this is like 2 days post, and they're just being babies about it, I'll ice them to get them moving. Sure. So I'll use ice as a therapy to decrease the pain to get them doing a movement I want them to do. Then once we're done with the movement, I'll put them in like a warm water bath with some Epsom salts just to kind of help soak and then promote the right amount of inflammation. I like to use a lot of instrument-assisted soft tissue mobilization on the tendons and ligaments. Again, controlled focal injury to a tendon to promote the right amount of cell growth and the right amount of healing.
But ultimately, you try to get them to load it because that's what the tendons respond to.
So initially for an ankle, it might be as simple as just like doing ABCs, just stationary, two-legged balance work, working on gait where they're using their crutches to go through full gait dorsiplantar flexion with their feet. So really promoting idyllic movements to try to keep them from losing anything. Because one of our biggest issues with ankle injuries is loss of dorsiflexion.
Okay.
Sure.
And once that's lost, it's so hard to get back. So if we start just training, getting them to use the dorsiflexion, walk normally, we get better outcomes. Research coming out of Australia is looking at the same thing with ACL recovery and initiating extension and full flexion as fast as possible gets people back on the court and field faster. I think an interesting... it's an N of 1, so I don't know where the research stands on it, but it is promoting a lot of additional research concerning, so I'm a huge hockey fan.
Okay.
Like I am all about the hockey. My team is the Edmonton Oilers.
Go Oilers, I guess.
Yeah. But there's
I'm
a
so
point to
out
this.
of hockey now. I'll just vote for your team because you're in the room right now.
Perfect. End of last season, their star player, Connor McDavid, he is so fast. He's the fastest skater with a puck on the ice.
Okay.
And in the skills challenge, he just lost being the fastest skater this year by like a second, but the guy who beat him can't handle the puck the way he does at his speed. Last year, he had someone take his feet out from under him. He went into the goalie's net and he tore his PCL. He tore his lateral meniscus and he completely tore his popliteus muscle.
Those are all seem less common.
Those are
That's
not
a weird sort of injury.
So it was and he fractured his tibia.
Yeah.
So it was that direct front on his shin, popped it back. And he was wearing all the appropriate gear. So first doctor he went and saw basically went, we have to get you into surgery. You'll probably go back to hockey in 18 months maybe.
Okay.
And he was like, don't like that.
Nah, if that.
I just signed a $10 million, like,
Yeah.
nope.
Gotta be better.
Opinion 2, confirmed. PCL, confirmed all the injuries.
Yep.
Gotta get you into surgery. You're gonna miss next season.
Yeah.
And he was like, nope.
Try again.
Flies from Canada to, I think, LA to see a chiro. And he went, what can you do for me? And he's like, well, let's see what rehab can do. So let's see if rehab will heal you. No surgery. This is not for everyone. They estimated what he spent in the 3 months in the off season recovering was about $2.2 million because he was
No big deal.
No big deal. So when people are like, do you know a chiro that could treat one person and make a living? I got one guy. I got one guy.
That guy can do that.
Basically moved in with Mcdavid, had him in barometric chamber while he was in the hypobaric chamber with a brace on, was doing quad sets and straight leg raises and just basic rehab while they were letting the fracture heal. They were doing MRIs every other day to watch to see if they had reconnection of the ligament.
MRIs every other.
Like just insane. And after 8 weeks, they actually started to see tendrils form between the ligament of the PCL reform.
That's crazy.
Yeah. No, this is insane.
Super cool.
After about 10 weeks, they actually put him back out. The chiro went up to him and was like, hey, don't tell your trainers. We're not going to tell anybody, but I just want you to go put some skates on and go out on the ice and skate with your dad. But we're not going to tell anybody.
All hush.
We're no aggressive stopping. Because he wasn't supposed to. I mean, the training staff had predicted the best they could do is get him back on skates in maybe November.
Okay.
And he's just like, go out. But I started a master's in sports psych. I hope to finish it. From the psychology point of it, he needed to retrain Mcdavid that it's not scary to be on skates.
Yeah.
Right.
So initiating that as soon as possible.
Yeah.
The bottom line of the story is Mcdavid got injured in the last game of last year and was on ice playing full out opening day of this season. He didn't miss a single game. Coming from the side point of every MD he talked to that said he had to have surgery, he was going to miss this season.
Yeah.
And he's leading score. He has the most points in the NHL right now.
That's huge.
Yeah.
That's amazing, especially with, I mean, so it was the ligaments
and that's
were...
after missing, he did have to miss 3 weeks recently because of a hamstring strain.
Okay.
But, I mean, they combined a bunch of, they got him a gymnastic coach. They started doing crazy training. There's an entire documentary that you can watch, but you can only access it in Canada right now. I'm trying to find it.
If your Google foo is strong, you'll
My
find
Google, we found it. It got taken down. But it was one of those things where I'm just like, our understanding of how the musculoskeletal system heals is drastically changing. One of my favorite conferences to go to is Current Sports Medicine by Fairview. Orthopedic surgeons present on a topic. The PTs present on the same topic, and they look at the research from both sides. And 2 years ago when I went, they were talking about shoulder impingement. The orthopedic surgeon stood up, walked onto the stage, and went, a research study in the UK came out looking at people who had all failed physical therapy. All failed physical therapy still had shoulder pain for shoulder impingement. One group was enrolled back in PT. One group was enrolled in the best standard of care, orthopedic surgery and PT. And one group was enrolled into a sham surgery. Okay. Create scars.
Yep.
Splash water, done, and PT. So with that, you would expect the group 1 and 3 to perform the same and group 2 to be better. And what they found is group 2 and 3 performed equally.
Yeah.
Scars helped people push through the pain of their musculoskeletal injury and do the exercises they needed to actually heal.
So it was more about they felt they had, what I'm hearing in that is that they had the confidence that a structure was in place. So even though
it hurt,
hurt doesn't equal harm.
Yeah.
That's what they were told. With the scar.
Yeah. Oh, or they went, I've had a surgery. I expect this to hurt. And I'm going to have to push through this.
Right.
They feel like I've already committed to a surgery. Now I'm at least going to finish it out with PT. I'm guessing the compliance is higher.
Yeah.
It seems like we are getting a narrative that's very well, if it hurts, don't do it.
Yeah.
Duh.
I've heard multiple professors have told us that.
Yes.
I prefer to train to tolerance.
Okay.
So that means I tell patients, I'm okay if it hurts, but I don't want you to get injured. Right. So if we're sitting at about a 4 out of 10, go.
Yeah.
Do. But if we're looking at like a 7 or 8, back off. So we might need to modify what you're doing. So, if deadlifting 250 pounds, 5x5 hurts, well, maybe we need to drop the weight to 185 pounds for a 5x5. Sure. Or maybe do a 6x5. So you didn't really lose anything, but we've modified it so that you're able to do this activity pain-free.
Yeah. We don't have to just lay them down and give them dead bugs. We can keep them on a bar.
No. You can keep them on a bar. I mean, not to dismiss dead bugs. I use them.
Yeah.
I eat the dead bug.
That's just a severe regression. If somebody really wants to be out there, it seems like such a severe regression.
Yeah, no, it really just depends upon what's going on. And that was something that they with Mcdavid, clearly that was a horrific injury. And they did regress him to basic, again, quad sets, straight leg raises.
Right. Sure.
And then brought him all the way back. And they said, we looked at all the insufficiencies he had, and we trained everything.
Sure.
So it was just crazy watching some of, they were doing, laying on your back, bouncing a ball, having to jump up, grab it. So you have, the change of really creating stressors and perturbations in the body to create different pressures so that when he went back out on the ice, he didn't have any fear and he was able to do whatever activity he wanted.
So almost taking injury as a time to work on your insufficiencies that you hadn't had time to in the the past.
Yeah. So it's a great opportunity to kind of look at an athlete and go, hey, we're going to have to kind of wind you down a little bit. Mm-hmm. We can't. Clearly, when you're out there performing at your highest level right now, you're having so much pain you can't do it. We need to step back and readdress this. Now, this is really talking about true musculoskeletal, ankle, knee, shoulder. I'm not talking about head injuries. Sure. Head injuries are a different ballgame. But even that's changing from like a blanket statement of you rest until you're symptom free. Mm-hmm. Now we're changing it to, yes, you rest for maybe the first 24 to 48 hours. Then we slowly start to implement tolerances. So, okay, first day you come back, you're having a slight headache. That's fine. Go jump on a bike, do some pedaling. As long as your headache stays the same, you're fine to continue. So it's more training, again, to the tolerance of the symptoms. But if the pain starts to increase, we take you off and we take you back down a step. So it's really playing within the realm, because when we create this fear, when we fearmonger their injury, we change their ability to perform at the levels they need to perform at. Mm-hmm. And that's what athletes are there to do, is to play and do at the highest level. So we take that to a regular patient. All they want to do is play with their grandchildren. All they want to do is garden. Yeah. All they want to do is go to the gym and lift and have that be their stress relief. If we're telling them you can't do this because you need your back to stay in place after this adjustment, we're destroying them mentally and just being flat out wrong.
Yeah. You mean their back's not going to just fall out of place?
Yeah. So when would you, other than head injuries, probably, like, it's, you know, if I was a marathon runner and I was like, come to you and my leg hurts, like, what would it take for you to be like, no, you need to stop running?
So runners are the worst. Y'all are nightmares. Because they've driven their body to just live off the endorphins of their run. They live off that runner's high. Mm-hmm. And when you take away that runner's high, you have a high risk of depression. Mm. So first thing I look at is, what are they running? What surface are they running on? What equipment are they using? How old are their shoes? Are they running on one side of the road every day? Because of the camber, especially in Minnesota, the camber of the road can affect how different one leg taking a stress or not. Is there some way I can modify the run to decrease the pain?
Even before reducing mileage, just anything else you can do.
Mm-hmm. So modify everything there. Then we look at mileage. Can we modify their mileage? Can we cross-train them with biking? Can we cross-train them with swimming? If they're not a swimmer, can we strap them with floats and have them run 0G in the pool so they still get their run in? Yeah. Can we, research has shown that of athletes that benefit from cross trainers, endurance athletes benefit the most from cross training in the gym lifting. So for actual performance bases, can I wind down their mileage, up their lifting, get them the same endurance feeling, and actually have them come out of it at a higher performance level? Mm-hmm. Now, this kind of all goes out the window when I'm dealing with a stress fracture.
Sure.
And then it's looking at appropriately making sure they're getting enough food. What's their calories? What's their micronutrients? So are they getting enough calcium? Are they getting enough vitamin D? Are they getting enough of magnesium? Are they getting enough to actually support bone growth and bone healing? What insufficiency? Why are they now in this reduced energy deficiency syndrome? It's no longer a female athlete triad, because they're recognizing it affects both men and women. Mm-hmm. So it's now red S, reduced energy deficiency syndrome. And how can we support their body through that? Because that's going to be the hardest one, because that I'm going to have to completely crank down their mileage potentially to 0, because stress fractures can become full fractures very, very quickly.
It also seems like, in that example, you've got a situation where there's legitimately a bunch of healing that needs to take place, whereas a lot of the aches and pains and minor injuries that an athlete has, I mean, you think, oh, I pulled my this or I strained my that. How much healing really needs to take place? How much is just the nerves are a little pissed off right now, and you just it'll just get better. You're fine.
One of the biggest things is having a runner switch sides of the road can almost resolve the majority of their issues.
Yeah.
Having them switch from concrete to a dirt path can change most of their issues. If runners get stuck on a pair of shoes and they haven't changed them in several months, shoes generally last 500 to 700 miles. Well, a runner can burn through that in 3 months.
Sure.
And have they changed their shoes?
It kind of reminds me of what you're saying. So again, we're getting a lot of narrative of like, how can we reduce? How can we regress? How can we support, brace? Support the arch, support the knee, support whatever. But we're sometimes I've got some chondromalacia in my knee, right? So there's this one little sticking angle that kind of bugs it.
Have you looked at the research on how many people over the age of 26 have chondromalacia?
Probably everybody, like most people.
80% of people over the age of 26 have chondromalacia. So oh, you cut.
I know.
Good job.
I know, right? Yeah, I'm falling apart at the seams. But it's like
I'm only 24, so
good for you.
But it's like whether it's because of that or not, I feel this little sticking point that just like at this one angle, it's really irritable. But it's so the advice that my PTs gave me at the time was, well, I don't bend your knee past 90. You mean ever? Yeah, that's just a thing that you just don't do now. Like, whoa, but like, how do I get back to that? Because I really like having full flexion of my knee. It's great, and I'd like to do it. So, but really, the solution I've found, and Dr. Oswald mentioned this too, is like actually the solution is more range of motion, deeper range of motion, because all this is pain free. This is all great. It's right around here is a little funny, whatever. And McGill also says this in Back Mechanic. He's like, oh, you got low back pain and walking hurts? Guess what? Walk faster.
Yeah.
Because the speed takes the load off of your joints, and it's increased motion.
Yeah. So
that's totally the opposite message.
For patella, I'll teach patients how to do their own patellar mobilizations. So we find what angle is their sticking point, and that's the angle they'll move their patella and decrease that sticking point for them.
Or that sensitivity.
Yeah. Same thing goes for...
Because I'm afraid of it now. Honestly. No, like, I know this.
No, it's true.
I know better, and I'm still afraid of a certain angle of my knee. So if I could just prove it to myself that it's okay.
It's fine.
I like that. I'm going to do that.
the other thing, like a lot of patients who have total knees are told you're never going to kneel again. That's not entirely true. The reason why they don't think they can kneel again is because it's painful. Yeah. Well, if they start desensitizing their knees. Now, of course, you got to work with your surgeon, you got to work with this, but if you start desensitizing it because it's the scar line, it's all the neurology on the front of the knee that's been screwed up. If you start like gently, like on a padded stool, just lightly pressing your knee down, pressing slowly, increasing that stimuli, you can get to a point where you have no issues kneeling.
It's like the first time you put a barbell on your back, it really hurts.
Yeah.
And then you just get used to it.
Yeah.
I'm also thinking like the patella was formed in the first place in infancy because you put a bunch of pressure over it slowly over time, and now you've got a bone.
Yeah.
Like...
Wolf's Law.
Yeah, it's like it doesn't just go away because you're not a baby.
Right.
So it's...
Unless you act... Well, actually, that wouldn't make sense.
It's one of those things where when people come and see someone, they're going to keep going until they find someone that tells them what they want.
Yeah.
And a lot of times with runners, with people who want to lift, who want to train, if they keep going and seeing people that say, you can't do this, they're going to leave. Now, there are people who honestly want to be told they can't do something because they want that confirmation bias that something's wrong with them.
Sure.
What do you do in that scenario? Because I imagine some people, if you come in and you basically say, all right, they sprained their ankle and they're hurting, and you essentially say, you're fine. Just go back. Why are you, go, run, whatever. Yeah, it hurts. You'll get over it. You're going to be fine without me. And they're probably going to think that you're
incompetent.
Yeah, exactly.
I had this happen. I have two really good examples of this. So a couple weeks ago, it was a couple weeks ago, had a kid roll his ankle in basketball, freaking out on the sideline. And I'm like, okay, kid, what happened? I felt a pop. Okay, pop's pretty significant when it comes, because did they avulse? Did they create a avulsion fracture? Did they tear the ligament? Mm-hmm. And then I find out, well, no, he didn't actually feel a pop. He remembered the injury he had from the year before that took him out for 3 weeks, that he couldn't play. Mm. And I'm like, well, did it feel like that? And he's like, yes, it felt just like that. I'm like, did it? And he's like, well, no, I just remember how bad that was. And I remember being so frustrated that I couldn't play. And I'm like, okay. So I checked his ankle. I used it's called the Ottawa ankle scale. It determines whether you need x-rays or not.
Okay.
Palpated everything. There was no tenderness other than right where the TFL is, the most common ligament injured in an ankle injury. And I'm like, okay, if this is all we're dealing with is tenderness right here, that's probably a grade 1. Mm-hmm. I want you to walk. And he's like, what do you mean you want me to walk? I'm like, I just want you to walk from here over there as normal as you can. And he just walked. He's like, oh, this isn't so bad. This isn't bad. I'm like, no, you're okay. Yeah. Do you want to be taped and put back in? And he's like, I don't think we're going to come back from this, so no. I'm like, okay, but I think you have a grade 1, no big deal. Versus a couple games prior, I had a kid, seriously, I'm like, okay, you need x-rays. Because it just instantly ballooned up, instantly swollen, instant bruising. I had some major concerns for what was going on. Mm-hmm. Now, when I have people come in with ankle injuries and I go, hey, I want to do something different because I want you, and I tell them, we're going to do something different than probably you've ever had before. We're going to start moving your joint sooner than you've ever have it moved because I want you back to whatever activity this is preventing you from doing as fast as possible. Mm-hmm. Yeah. And usually, again, I work in a very cloistered population of athletes. They want to get back to their activity. So they're like, sweet, whatever you want me to do, I'll do it as long as it gets me back.
I would guess if you find that one thing that patient loves to do, even if they're not an athlete, you probably, like they garden or even just walking up their steps. You find
it's one of the best ways to set goals within your charting. When I'm first meeting with a patient, when I'm getting their history, I more or less think of it as this is the patient's story. I want to hear the patient tell me what's wrong with them in their own words. Mm-hmm. So I try to just sit back and listen and have them tell me what their frustrations are, what they can't do. And I'll chime in with a question here or there to guide them, get the necessary things I need, like a pain scale or any red flag questions. But I start them off by just tell me why this is bothering you. Because in the minute they can tell me what's wrong, it gears my entire exam, my entire treatment plan around how do I get them back to this activity because it's going to up patient compliance.
Yeah. It seems like we are, at least from my perspective, people are afraid to not treat. People are afraid to, when you think about how many injuries essentially are just going to get better on their own and patients don't need manual therapy, it has me wondering, well, then why are we useful to those patients? Which my immediate response is, oh, okay, well, we can provide a diagnosis because
peace of mind.
We can rule out more serious things and then give a reassurance and tell them, you're going to be okay. Keep moving. Yeah, it's going to be a little uncomfortable, but you're going to be fine. You're not doing more damage. Get out there. And it seems to me that people are afraid to not treat them with their hands, not adjust something or grasp in something or cup something or tape something or just got to put your hands on people. It's like, how often do you just just give the education, the diagnosis, the reinsurance, and say, no, you got this. You're fine.
When I'm on sidelines, a lot.
Yeah.
A lot. If a patient has taken the time to come into clinic, generally there is something I need to do for them in clinic. Now, do I adjust every patient? No.
Okay.
Do I do instrument work on every patient? No. Does every patient get some form of exercise or movement-based activity?
Okay.
Yes.
Is there any, so are there a lot of patients that get the exercise, which it seems, in my reading of the research, it seems like that exercise plus education is like the single greatest, plus reassurance is like the greatest treatment you can give a person.
Yeah.
So are there a lot of patients that you don't give any passive therapies? Passive being, tape, your hands on them, doing a thing to them.
So this is where it gets a little complicated because I use factor principles. Okay. But I very rarely start them off at level 1 factor where they're just immobile. I put cups on them and I'm instantly having them do activity.
Yeah.
So you're kind of combining the...
So I blend the passive and active. I want them actively involved.
Yeah.
I want them actively doing stuff. Now, do I adjust? Absolutely. But I make sure that it's what the patient needs. Now, do I have patients coming in that are just like, I just want to be adjusted. I know you don't think I need it and I just want to be adjusted. Yeah. Do I adjust those people? Yeah.
Yeah.
Because it's what they want.
Right.
And if that mentally helps them keep moving, if me adjusting them provides them their mental reassurance to go out and work out.
And it's not like you're telling them that they need you. You're not telling them that their bones are in the wrong place. You're not telling them that they're going to fall apart like a Jenga tower.
No.
They just really want it. And you're like, okay. And you educate them about it. And I don't...
They still want it.
Yeah.
No,
I don't see the harm in that, really.
Probably my biggest issue is, so treatment plans at my clinic range from 4 to 10 visits. That's basically it, depending upon the complexity. I do have patients that I have on longer, like maybe once a month, maybe every other week, because they have long-standing conditions that cause issues. Like if you have chronic migraines and you respond well to adjusting and don't have to be on medication. Yeah. That's really hard. But I mean, I'm combining it with neck strengthening. I'm combining it with stretching. But if that adjustment is just what keeps them at bay, I don't know why. It helps them. Am I saying, oh, your neck's out? You're offset? No. There's something in the body positioning, the biomechanics of what you've been doing that has caused tension. And this is alleviating that tension and preventing you from having a migraine. Cool.
Yeah.
I don't know. The joys of our profession.
Can you speak a little bit about, like, you talk about, like, some runners, like, they could develop depression if you take them off. Like, how much do you consider the mental impact of, like, pulling someone out of their sport? Because I feel like a lot of providers are pretty laissez-faire about, like, well, just take 4 weeks off. You'll be fine. And it's like...
I take the mental consideration with every patient. That is something that I feel is so underaddressed that it creates performance issues. It creates fear-based movements. Probably a great example of when I've taken this almost too far. Not quite too far, but almost too far. It was an athlete's senior year. It was the second game of the season, and they broke their clavicle. Granted, when the athlete came off the field, they were like, something's just not right. I just can't lift my arm up. And I'm like, really? Okay. So in my head, I'm going, well, did they do they have a slight separation of their AC joint? Did they just do a strain of this or that? And when I finally got in and palpated the clavicle, I ended up like this. And I was like, hey, bud, how you go? You broke your collarbone. And he was like, no, I didn't. And I'm like, yeah, you did. So a cut them out of their gear, got them splinted up, talked with mom and dad. And I was like, okay, here's the deal. We have 3 options. Option 1, since this is the first quarter, I can call an ambulance, have him transported, get x-rays, blah, blah, blah. Option 2, you can drive him right now. Go get this taken care of. Option 3, we stay till halftime. By then, he'll have recognized he's actually injured. He'll have accepted his injury, and he'll be able to have communicated with his team and cheered them on and recognized what's going on. And they were like, I'm like, but if he stays on, he has to pass all of these tests every 5 minutes. He can't, I set some pretty specific ground rules concerning circulation, motor, sensory, like making sure there wasn't additional damage going on, what he could or couldn't do while he was on the sideline. And he basically he was going to be my shadow for the rest of the that half. And they opted to go with option 3. And because we did that at halftime, after he spoke with the team, he went, I'm ready to go. I recognize I'm injured. I recognize why you did this, and I thank you. Got him in. He ended up having to have surgery. But we got him back for the last game, playoff game of the season as a punter.
Sure.
On the field, at least.
On the field.
Part of his, his team on the field. Yeah.
And that was a huge thing. But that was just playing with the mental aspect of, if I had just yanked him off the field and thrown him into his parents' car, he never would have accepted his injury. Because then he came back and he coached the rest of the season on the sideline and helped kind of guide the team that way. So he was able to take on that role. Versus when you have those season-ending injuries, having them come to terms with it as soon as possible gets you better outcomes later on.
Yeah.
But mental health, every patient's mental health is an important piece, because whether you've been in chronic pain, had an acute injury that pulled you from something you want to do, mental health becomes a piece of that. And addressing it directly helps get people better faster.
Yeah, it's amazing to me how much the mental factors and social factors determine health. You're doing you're in the middle of sports psychology. Where are you doing that?
I'm doing it online through Capella.
Okay.
And I paused it because I have a lot going on.
Yeah.
I have a lot going on, but I plan on starting it up again in the fall.
Yeah.
And getting through that, just because they have a flex path, so I can do it at my own pace.
What does that give you that most chiropractors don't have? Is it mostly? I don't think it's going to change any kind of scope, but in terms of education, what?
I think it will help me clean up language when talking about injuries, and will help me provide the right combination. There is a way to convey to a patient that they're hurt and injured and they have to take a break without making them feel disabled. And I just want to get that language as polished as possible. And I think this gives me that education. It also gives me better skills with coping when you have potentially someone have a suicidal episode or have an acute flare. And I've had athletes that just get the right combination of back-to-back injuries that have had suicidal episodes and have been their point of entry into the mental health realm at that point, because I was the person that asked, are you having thoughts of suicide or self-harm? Not a lot of people are comfortable asking that question. And it is something we have, if we're going to be a primary care provider, if we're going to be portal of entry, we have to be willing to ask that question to make sure we get them into the right portal. Yeah.
People have such inaccessible, I guess healthcare is not super accessible to begin with. So if they got in to see any healthcare provider with doctor in their name, who can make a proper diagnosis, then it seems like it's our responsibility to properly screen and refer and recognize those kinds of signs and things like that. I think that's you've seen some conversations I've been having recently on the sidelines, let's say, but it just seems like I think a lot of the difficulty as a student looking at the profession I'm about to enter is not necessarily with, oh well, this technique is better than this technique, which I like to have those nitty gritty debates, but I think the bigger picture is that what you just bring up is like, there's a way, way, way bigger and more important thing that any healthcare provider really should be doing, and that is making sure that we recognize when big stuff is going to happen. And a lot of that is we haven't really gotten any of that. We got one questionnaire thrown at it, like kind of linked in a online page. It's like, hey, if you get your spidey senses tingling and you think somebody's got suicidal thoughts, then give them this additional questionnaire. But that's all we've gotten so far.
As far as like suicide.
How to recognize when somebody really needs some mental health.
Well, I'm going to tell you, there is no spidey sense. There's no perfect questionnaire. There is just the questions.
Yeah.
Are you feeling suicidal? And are you having thoughts of self-harm? If they answer yes, the next question is, do you have a plan?
Yeah.
That will, because for the most part, people who, statistically speaking and looking at the research, people who attempt or commit suicide have seen a medical provider of some sort within 7 days of that attempt.
Yeah.
Which means someone didn't ask the question.
Or they asked it, but they were reading off a clipboard and
But generally, if you ask or the wishy-washy, are you feeling sad?
Yeah.
Have you been feeling depressed?
Yeah.
Have you just not been feeling off?
Yeah.
Well, the patient's like, you're not seeing me for what I am. When you spell it out, are you having thoughts of suicide? No patient has ever lied to me because they're going, oh, you actually see me.
Yeah, you're paying attention to me as a human being.
And they'll answer truthfully. Every time. And then you got to know what you got to do after that.
That was exactly what I wanted to ask. Like, okay, so now you get a yes to that. You're now confronted with something that we so far are not. We don't know how to handle that. I mean,
this is what I teach in emergency care. You can't just give them
a card.
No, this is what I teach in emergency care. So I teach mental health emergencies. It's a 1 hour lecture. Here's what you do in these scenarios. And frankly, the movie The Joker is a beautiful portrayal of the accurate depiction of our mental health system. So mental health comes very close to home. My husband has severe clinical depression with suicidal ideations. And it is something that when we were working through his diagnosis, we started off with a counselor. He went to it fairly well for like 5 months, but then he's just like, I'm not getting anything out of it. But he refused medication. He's just like, I don't want to go on it. I don't think it'll help me, blah, blah, blah. And you can't force someone. Well, it started to manifest in physical symptoms. His headaches got worse. His irritable bowel syndrome got worse. He got severe low back pain. He had muscle aches. He had the worst headache he's ever had in his life. Which, if you're a chiropractor and someone says to you, I'm having the worst headache of my life, like, freak not a good, which then, I mean, at that point, I'm like, all right, let's pack this system up. We went and got an MRI. It showed increased white matter, which got us a neurology referral, which that neurologist then started an entire MS potential diagnosis with a diagnosis of suboccipital nerve. Like, it was just a snowball of overwhelmment, which if I hadn't had the knowledge I had, I'd be like, oh my God. It turned out he was having suboccipital neuralgia headaches, which we treated with acupuncture. They wanted to do spinal Botox injections. That was their first step. And when I was like, you want to put Botox where?
Please try something else first.
Can we try some acupuncture first? And he's like, I guess it won't work. One treatment. It took one treatment with like 2 follow-ups, and he has not had that headache ever again. But to get into a psychiatrist to actually get meds, because he finally admit, I think I need meds.
Right.
3 months.
Yeah.
And 3 months with great health insurance,
Right.
and me going, I don't care where in this state I have to drive, get me an appointment. And they're like, no. That is the wait list for anyone.
Mm-hmm.
They're like, but if you're having issues, just call 911. We'll put them on a 72-hour hold and deal with it. And I'm like, I put him on a 72-hour hold. I'm losing any trust I've built with him.
Mm-hmm.
Yes, he's my husband, and yes, he trusts me. But if I do this, all of that goes out the window because I've literally had him committed.
Yeah.
But that's sometimes all you have. And a lot of insurances, so the Affordable Care Act put mental health care in there. Since it has now been modified, mental health care has been pulled out. And a lot of times they'll only cover 72-hour holds. So it is an incredibly challenging piece to manage. When you ask the question, you get that answer. Sometimes your only option is to put a 72-hour hold on that patient. If they're in that acute distress, they'll appreciate that. I luck out in where I practice, just down the hall, there's a full counseling service. And I've gone in and talked to them and been like, hey, if I have an acute suicidal emergency, can I call and you'll come down here? And they went, yes. So I'm a little spoiled.
Yeah, but even if you have a good relationship with someone 3 miles away, we're in the Twin Cities, so
they're everywhere.
Yeah.
They're at least from the counseling side of things, they're pretty much everywhere. You can get access to something. There's also the suicide helpline. There's some other national phone calls you can make, but we suck at mental health care.
Yeah.
It is mental sick care.
Yeah. And it doesn't help at all. It seems, it's the thing that keeps impressing upon me every time I hear any kind of story like this is that, with regards to what we are going to encounter in the future as chiropractors, is that a lot of people are going to come into our office and it seems like it's going to look like a duck and quack like a duck, and it's not a duck at all.
No.
Not even close to a duck, right? And if we just go duck hunting all the time and, No,
I mean, our history and exam, not to beat a dead horse that Dr. Stu McGill threw out there, but your history and exam is your everything.
Yeah.
And you do have a limited amount of time. Like, I spend an hour with a new patient, and 30 minutes of that is generally a history.
Sure.
Because I want to know every aspect of this person. I want to understand exactly what's going on, because that helps shape and helps me predict when there's going to be additional issues.
Yeah.
And I mean, I practiced after I finished my fellowship, I went and practiced in a clinic as an associate in another state. And there was a patient that was sent to me because they were having knee pain. And I'm like, okay, I'm the extremity guru. Cool. I'll check out and I'm pretty decent with knees after working with a women's professional football team, because you combine women in contact with their knees. Oh, bless them. So I get to this patient. I'm like, okay, I'm going to put you in some shorts. I want to see what's going on with your knee. They had seen another provider in this office the night before. Put the patient in the shorts, come in, look at it. The one leg is 2 times as big as the other leg. This is a healthy individual, late 30s, early 40s, physically fit.
Yeah.
I go and poke their leg, and my finger indents an inch. I pull it away, and it stays.
Cellulitis leaf.
Yeah.
Draw your marker around it. And
Ding.
Draw a marker. Bye. ER for you now.
Yeah.
Then I call this other provider. I'm like, why is this person in our clinic? Oh, it's just knee pain. Did you look at the knee? No.
They didn't even look at it?
Oh!
With their eyeballs?
No! But this is how lazy we... Like, do you have to gown every patient? No. But you need to visualize what is the area of complaint.
Right.
Yeah. Instead of being like, no, I don't adjust knees. Go see someone who adjusts knees.
Ah!
Yeah.
But, I mean, that kind of epitomizes, and I think at the school, we do a disservice when we don't, so PDX, NDX, EENT, cardiopulm, GIGU, women's health, that is your basis for your exam and your history.
Yeah.
And we cram them in at such high credit loads, you can't process, you learn and purge.
It's tough.
Yeah.
It's tough to keep up.
Yeah.
So when we get you in clinic, and I'm the worst for this, patient comes in with a headache. I want a full ear, and I want a cranial nerve exam. I want an eye exam. I want an ear exam.
Mm-hmm.
Because that can all lead to headaches.
Yeah. If you're really differentiating
Yeah.
and making a diagnosis, you have to actually rule things out.
Yeah.
Yeah.
And a lot of students look at me, they're like, I haven't, what? And I'm like, get your doctor's bag.
Yeah.
Go.
Remember that bag?
Yeah, remember.
You toted it around for a couple trimesters? Well.
It's at home.
Yeah. Yeah. Sorry, I sold it.
Yeah.
Don't even. Oh! Whenever I see those being sold, I'm like, okay, if you're gonna have the wall-mounted units in your clinic, fine.
Yeah, if you're trading up.
Fine. If you're upgrading.
Yeah.
But when they're like, no, I'm just selling it. I'm like, oh.
Yeah.
But
Sell your doctor title also.
Yeah, please.
Like.
so I look at it. There's really two different types of chiropractors. There are doctors and there are technicians.
Uh-huh.
And how we differentiate ourselves is I see myself as a doctor. I'm a primary care portal of entry musculoskeletal expert.
Uh-huh.
That is me.
Yeah.
How can you educate the public on the difference, or should we?
So I do my best with educating. I have a YouTube channel.
Yep.
So Mobility, Agility, Chiropractic Performance. It's a YouTube channel. I provide weekly Facebook Lives where I go in and I talk about a topic and I cover it comprehensively. So every Tuesday, 6:30, tonight I'm talking about low back. And I'm going to do a 2-part series on low back. And I'll show them x-rays. And I'll show them basically how to read x-rays. Mm-hmm. And when you see degenerative change, is it a death sentence?
Mm-hmm.
No.
Right.
Like
most people have that.
Yeah. So I try to just put as much content of value, of education. Mm-hmm. I try to bring them to a level that they go, I can make an informed decision on my own. And I do the best I can. I try to represent myself that way. I try not to share posts that are questionable. Very rarely will you ever see me see a post like, oh, it's Monday, come get adjusted.
Right.
Oh, it's Friday, get adjusted, start your weekend right. Yeah. I don't do those posts.
Sure.
Because I don't think you need to get adjusted to have a good day. You don't have to get adjusted to have a good weekend. Do you need to make sure that you're functionally moving? So I was thinking about this morning concerning posture. Does posture matter? Mm-hmm. And I think I finally figured out how it both does and doesn't matter.
Oh, you cracked the nut.
The crazy train of thought brought me here. Posture is non-predictive of pain, but posture does affect function.
Okay. Like, if I'm slouched, I literally just can't reach overhead.
Right.
Not because there's anything wrong with me, but I just have less available range of motion.
Right.
Okay.
So posture isn't predictive of pain, but can definitely influence the ability of the person to function and what compensatory patterns have they developed that then cause pain.
Sure.
Do the patterns cause pain, though?
I don't know.
Like, if you're slouched,
constantly doing overhead work,
right,
and you're constantly being here, and you're jamming your glenohumeral, into your acromion.
Uh-huh.
Wolff's Law is going to kick in eventually. You're going to develop bone spurs. Then the bone spurs are going to rub more aggressively on the tendons.
Sure.
That potentially could cause pain. And that could be, here's also how I look at pain. Pain is not necessarily indicative of an injury. It's your brain's only way of communicating, hey, I'm trying to tell you something's not moving right, so I'm going to make it hurt so you're more aware of it. Mm-hmm. So a lot of time...
It's not tissue damage. It's your body saying, this isn't super efficient.
It's proprioception loss. Why does kinesiology tape decrease pain?
Because it feels
Because you can feel you have better proprioception.
Right. Yeah. Right. That's something you said earlier too about when I was asking about not treating people who have innocuous injury that's they're going to get better anyway. Yeah. Who cares? Don't even touch them, right? But to the point of proprioception, that's the only valuable thing I could say is that about doing a manual therapy on a person or putting some kinesio tape on or grassing it or just massaging it or whatever is now they feel that area, and that as long as you don't sell them a bill of goods like we're putting things back into place, we're like I'm doing something special and fancy. If you're just like, hey, you're gonna get better anyway, but it might just feel nice today to have a little of this done or that.
I both love and hate tape with like a deep-seated passion. So we don't want to go down that route. But that's where I think where McGill got into like posture matters.
Right. Yeah.
He was talking about function.
Sure.
Versus where posture doesn't matter, we were talking about pain. Mm-hmm. And we just had a disconnect there.
Yeah. Yeah, the other thing that I thought of when you said when you're talking about shoulder impingement is like I would be really curious to see as regarding Wolff's Law, like how much pressure do you need really to change bone formation so that it's so much that you get osteophytes. But the thing that I could definitely buy without needing to see any research is that in a crappy even calling it crappy posture in a flex posture that limits my available range of motion.
Biomechanically inefficient.
Yeah. It is. If it's inefficient if I want to reach overhead. Yeah. It's really efficient if I want to tie my shoes, right?
So it
takes more effort to do this. If my goal is to reach overhead and I slouch my spine, it takes a hell of a lot more effort for my muscles, and they're just going to fatigue more quickly. And I could with less effort in my shoulder muscles, I could just sit up taller and do this. Yeah. But I think that's the thing people get really dogmatic about is like this is bad posture for what? Because again. For tying my shoes, it's great posture.
If you're trying to do an overhead squat, you're gonna hurt your shoulder.
It's all about again, what is the function of what the person wants to do. Yeah. It all comes back to what is the activity the person's trying to do? Why is it hurting while they're doing that activity? How do we get them out of pain?
Mm-hmm. Oh, so we have to like troubleshoot and problem solve. We can't just say posture matters all the time and that forward head posture is the devil and can't just say that?
No.
Sorry. People are complicated.
Can't just be lazy about that. It's too bad. Did you have any last minute questions?
I don't think so.
Okay. The one last thing that I just want to ask is for students, if you can try and remember when you were
it's not that long ago.
Well, I can't remember what happened last week, so
okay.
I'm coming from that aspect. We're T5 out of 10. Anyway,
we're almost halfway.
Yeah, so we're about halfway through. When you were about halfway through, what would have helped you move through the program? I'm sure you saw some stuff that was going on in the profession that maybe wasn't thrilling. Some difficulty with classes, difficulty with whatever.
I mean, T5 has actually changed quite a bit from when I was a student. So T5, the clinical nutrition class that you have in 5 and 6 used to be one class in T5.
Okay.
And we had boards right in between midterms and finals.
Nice.
That was our T5.
Nice.
And if I remember correctly, our T5...
Small improvements.
Our T5, we only had a 10-day break between T5 and T6.
Okay.
So we came to T6 and we're just delirious. When it comes to students, what to kind of look at is recognize the fact to be the best clinician, provider, the best future chiropractor, by my definition, you're not necessarily going to learn everything in school, but you're going to get a hell of a foundation. And pay attention to the classes that don't seem chiropractic related. Those diagnostic classes. That is your bread and butter of actually being, when you can have someone come in and you can give them an actual answer, not hogwash, but an actual answer that helps them get better. That is both satisfying, but that's where the money's at. When you can be the expert at diagnosing and actually helping someone, that is when you become successful.
You do your exam and send them to the person they need to be at.
Then they go
refer all their friends. And chiropractors really get obsessed with holding on to patients.
What drives me insane?
It's like,
I am not.
You don't own them.
I'm not emotionally. I mean, like, I love my patients. I adore them, but I am not attached to them. I've been told I need to do a better job of just being okay with treating everyone, and I'm not. I do not want to treat infants. I don't want to treat them. I really don't want to treat pediatric patients. Not because I can't, but because I'm not an expert. I want them to see an expert that has done the 100 hours in pediatric course care that actually understands how to get them better. I haven't done that. Why do you want to see me?
They're different. They're not just tiny
They're not
people.
tiny. They're not tiny adults. They are cartilage aliens.
They are so weird. The first time I saw a kid on an X-ray, I was like, "What is that?"
No. And one class in T7 of like child's health,
cartilage aliens,
does not make me a good doctor for your 2C. You don't. I mean, look at the medical profession. It is not the olden days where you go see a barber surgeon to have your tooth pulled and your boil land. Like, you don't, that's not how it works. You have specialists for a reason. And if we as a profession were better at inter-referring just within ourselves, patients would have better care. But people get so attached and so fearful. And the student loans are a big deal. But you gotta, if we're gonna grow as a profession, we need to grow in the way that we create a care team. Every person needs a care team, whether that's a singular person at that time, but generally as people age, they need more people brought in to remain at the highest level of function. And if you as the chiro can be that portal of entry, center of care, you can help keep them from going down crazy places. Not to say the general medical is not, that does create, they don't, but they sometimes do.
So takeaways I'm hearing, don't scare your patients, take the doctor part seriously, be a good team player, and do a goddamn good history and exam, and
keep people moving. Let them move.
Awesome. Dr. Mac, thank you so much for joining us.
Thank you.
You're welcome, guys. That was fun.
Cool. Tell everybody your website again and anywhere that they can find you.
Okay,
what is
so Clinic, Mobility, Agility, Chiropractic Performance. It's also the name of our YouTube channel. We're on Instagram at MacP_clinic. We're on Facebook at Mobility, Agility, Chiropractic Performance. And our website is macperformance.clinic.com, I think. macperformanceclinic.com, and that's where we have our blog. We post 2 blog posts a month covering different topics of interest, from how to reduce pain as a desk worker to concussion prevention. So kind of all over the place.
Awesome. Follow Dr. Mac. Like, subscribe here so you can see more videos when we do these kinds of things. And thank you for joining us on this episode.
Thank you.